Hello and welcome to our session on postpartum care for birthing people with HIV. I want to acknowledge that I have adapted this presentation from a former one by Dr. Emily Miller, who was a prior faculty member in our OB/ID clinic. Our goals in this session are really going to be thinking about transitioning from the inpatient setting to the outpatient setting and planning someone's postpartum course. The first step we'll talk about is that in immediate infant care and what needs to happen in the labor and delivery room immediately after delivery. A lot of these processes happen automatically, and Prentice is a very well-oiled machine, but we really want to make sure that we are consciously aware of these important considerations and that they are happening in the background, or making sure when this communication happens that it is seamless. The concept here is that we want to minimize infant exposure to maternal blood and bodily fluids. One of the mainstays of how we do this is we want an early infant bath to wipe down the infant's skin as soon as possible after delivery in the LDR and prior to any prophylactic antibiotics or the vitamin K injection or other injections, as we say, prior to eyes and thighs. Then we want to administer infant antiretroviral prophylaxis right away. We'll briefly talk about the nature of what type of prophylaxis we give in a minute, but this should include all babies, including those with low birth weight or low APGAR scores. We really want to make sure that we can get them these medications as soon as we possibly can, and certainly within the first hour of birth. And then finally, in terms of a safe feeding plan with formula versus breast and chest feeding, hopefully a lot of this conversation has happened in the outpatient setting, but certainly if this is a new diagnosis and we're talking about mode of feeding, we want to make sure that we're engaging in culturally affirming shared decision making. Now let's circle back to the medications that we give for postnatal neonatal prophylaxis. And this is a really important study, the PACG 1043 trial, that has really reshaped how we think about postnatal prophylaxis. The concept here is that at the time of this trial, the standard of care was to give neonatal zidovudine postpartum, also known as AZT, to infants for 6 weeks, and we knew that this dramatically reduced the risk of perinatal transmission, particularly in high-risk exposures. And what this study did is it took birthing individuals that were at high risk of perinatal transmission and randomized them to either zidovudine or double therapy with nevirapine or triple therapy with zidovudine, lamivudine, and nelfinavir. And in this randomized trial, there's two things that I want you to remember that the blue and the green bars highlight. The first is if you look at these blue bars, these are the infants that were infected in utero, which we know from the timing of the testing. And what you can see is there's really not too much of a difference between those that got zidovudine versus double versus triple therapy, whereas there is for infants infected intrapartum in green. So the concept here is that if we know that if an in-uterine infection has already occurred, monotherapy with zidovudine is not really going to do anything. But the real impact is for those infants who are infected intrapartum, as depicted in the green bars. Compared to zidovudine monotherapy, where there was around a 5% risk of perinatal infection in those with intrapartum infection, the neonates who received double or triple therapy had that risk cut in half, and this was statistically significant and really clinically significant, such that we could reduce the risk in these neonates with these incredibly high-risk exposures to be around 2 to 3%. And so this is a trial that really changed the landscape for our high-risk pregnancies. For high-risk infants, in our guidelines, we recommend triple therapy for postnatal prophylaxis. Now you might say, well, why not double therapy instead of triple to reduce additional drug exposures? And the thinking is that by giving only double therapy, we may see drug resistance develop in those who do in fact become infected, and so triple therapy would reduce that risk of drug resistance developing. So when I say an infant is high risk, how do we determine this? In the PACG 1043 trial, it was extraordinarily high risk, but we should expand on this a little further. Many of you have seen this slide before, which I've pulled from our Illinois Perinatal HIV Hotline Manual, but it's really important to refer back to. These guidelines for what qualifies as high versus low risk have evolved over the years, but were developed on the basis of evidence that moms who had not already been on antiretrovirals before or during pregnancy or have detectable viremia throughout the course of pregnancy and especially proximal to delivery all dramatically increase the risk of perinatal transmission. And so building off the 1043 trial, as well as additional data from the French perinatal cohort study group, we have defined infant risk status as high risk if at least one of the following is present as listed here in the bullets on this slide. If we jump to the last point, this really captures the point of heightened perinatal transmission risk with late viremia. The high-risk category also includes anyone who did not receive prenatal care or ARV therapy antepartum or seroconverted during pregnancy, as this is a major risk factor for perinatal transmission, and anyone, of course, who has been diagnosed during labor or postpartum. If any of those aren't met, if any of those are met, then we would consider this infant high risk and recommend triple therapy. But if the infant doesn't meet any of these criteria, this would be defined as low risk. In terms of the specifics of the regimens, they're listed very generally here, and I won't read them off to you, but it's important to go back and reference this in the perinatal guidelines, also in our Illinois HIV hotline manual. And we need to make sure that we have the right dosing in the right time frame, and especially, again, initiating these medications within the first hour of birth. And this involves active communication and coordination with the hospital pharmacy and nursing staff prior to delivery, as well as our neonatal colleagues prior to, at time of, and after delivery in order to make this happen. For low-risk infants, typically 4 weeks of postnatal zidovudine is used as monotherapy, but I've placed an asterisk here as there are some very specific instances where 2 weeks may suffice, which will be reviewed by our pediatric colleagues in a separate session. There are a couple more points I'd like to emphasize. One is that while we would typically consider high-risk infants continue the zidovudine for a full 6 weeks, the lamivudine and nevirapine can be discontinued if the birth PCR is negative. If the birth PCR is positive, that infant needs to be closely followed by our pediatric infectious disease colleagues in order to guide further medical management. Additionally, for our preterm neonates, there are special dosing considerations, and so for infants that are preterm, we need to go back and reference our hotline manual or institutional protocol that defines gestational age windows and infant birth weight and how we dose this appropriately. And then for those that are extremely premature, under 32 weeks, we would call our pediatric infectious disease colleagues to help guide us with postnatal dosing. In terms of infant feeding, this has been an area of significant controversy, and recommendations are actively evolving, with the National HIV Perinatal Guidelines incorporating updated guidance in 2023 about shared decision-making regarding breastfeeding in the setting of U=U, including in high-resource settings. This will be reviewed in detail in another session, but I want to highlight a couple points. Tenets to remember is that HIV is found in breast milk, and that if women have detectable viremia, an additional 15 to 29% of infants can become infected. Breast or chest feeding is unequivocally a mode of perinatal transmission, with both the times of actively breastfeeding and weaning from breastfeeding as high-risk periods, and the postpartum period overall being a high-risk period in general for ARV adherence interruptions, etc. In the past, the national guidelines had recommended that people with HIV in high-resource settings avoid breastfeeding. However, we've come to realize just how important it is to respect the social and cultural norms surrounding breast and chest feeding and to engage in shared decision-making with our patients. This involves informed discussions about the risks of postnatal transmission and various risk-reducing practices to make breastfeeding safer should they ultimately choose this method of feeding. But what's really important to remember is that mixed feeding, meaning breastfeeding and formula feeding and alternating between the two, has a higher risk of HIV transmission compared to exclusive breastfeeding alone. And so for this reason, it's important that we talk to our patients early and often and openly about a safe feeding plan during their prenatal care visits and reinforce this plan postpartum so they understand the risks involved and in the investment it takes to breastfeed safely, or ultimately utilize strict formula feeding if that is a better route for them. As one example, if a patient intends to formula feed, it's really not okay to suddenly start breastfeeding when their mother-in-law is visiting to try to avoid disclosure of their HIV status, but then go back to formula feeding in other settings. So we need to support them in navigating this mode of feeding decision and then troubleshooting how to make this work despite potential challenges that arise in real life on a day-to-day basis. Ultimately, mode of feeding is a dynamic consideration and discussion, and while the risk may be low in someone on antiretrovirals who has sustained viral suppression, it's still hard to prove that there's absolutely zero risk. But engaging in that shared decision making about the benefits of breast milk, benefits of direct feeding, and direct breastfeeding, and then what sustained exclusive breastfeeding could look like, all while in the context of transmission risk, this is really essential. It's also really important to flip this on its head and say, if we think it's so important to dialogue with birthing people with HIV about this, it's also really important for us to know the HIV status of all people who are breastfeeding, and so thinking about what this could really mean from a public health lens. Up to this point, we've been discussing mainly inpatient and infant care, but when we think longitudinally, we want to remember that we want to set these birthing individuals up for success afterwards in the postpartum period and interpregnancy interval. And so this includes referring people to specialty HIV care if they're not already linked, and considering possible changes to their antiretroviral therapy. If someone has been on a complicated regimen to support the prevention of perinatal transmission, for example, we can potentially simplify that regimen by converting the person to a once-a-day regimen to facilitate long-term suppression beyond the perinatal and immediate postpartum period. We also want to make sure that we're checking the CDC guidelines for any drug interactions with antiretrovirals, and we want to make sure that we're monitoring for adherence postpartum. To that end, postpartum depression affects many of our patients with HIV, and depression can interfere with their medication adherence, follow up with their providers, their ability to care for their neonates, etc. And so risk of postpartum depression is really high in our patients with HIV, and especially those with a new diagnosis. And so considering a follow-up visit or telehealth check-in within 2 weeks after delivery is an important consideration for these individuals at risk of postpartum depression. It's also important to remember the entire family context. And what I mean by that is thinking about any older children, especially for those patients with a new or recent diagnosis. Consider when this patient has birthed before, have her kids been tested before, was this person tested in a prior pregnancy, when was that last negative test? And so we can facilitate who needs to be tested within that family unit and follow up any sexual or needle sharing partners. In addition, we need to address breast and chest care, meaning supporting lactation suppression in those formula feeding with ice packs, tight bras and compression, avoiding pumping, use of Tylenol and ibuprofen for discomfort, versus addressing breast care to avoid mastitis or discussing what to do if mastitis develops for those who choose to breastfeed. Lastly, contraception is very important to readdress in the postpartum period. It's important that we discuss contraception from the lens of promoting self-efficacy and self-empowerment in active family planning among pregnancy-capable people with HIV. This conversation should start in the antepartum period, but should also be reinforced postpartum. We need to address what are their plans for potential expansion of their family in the future, to address safe spacing and timing of any future pregnancy. As we know, this can serve to optimize the person's long-term health, their future pregnancy health, future pregnancy outcomes, and also to prevent unintended pregnancies. We also need to consider any drug-drug interactions between hormonal methods and ARVs, as mentioned before. And then in terms of efficacy, while we know that efficacy increases on the continuum from short to intermediate to long-acting or permanent options for contraception, the most effective form of contraception is ultimately going to be the one that the person's going to use. Not to repeat anything from the safer conception talk, but discussing safer practices goes hand in hand with our contraception discussions postpartum, including, again, the importance of ARV adherence and maintaining viral suppression postpartum, use of dual protection with condoms for other STI prevention, plus minus PrEP based on their level of risk aversion, and especially if there are any adherence concerns, both in order to prevent horizontal transmission to a seronegative partner, or likewise to prevent acquisition of resistant strains of HIV from a seropositive partner. And ultimately, it's our job to make postpartum follow-up and attainment of contraception feasible and accessible. This concludes our session on postpartum care for people with HIV. I've listed a few resources and references here. Thank you so much for your attention and being a part of our HIV Bootcamp series, and we look forward to more of this discussion soon in person.